Okay. Thank you for joining us today for the Geriatric Grand Round program. This program is provided by the Michigan Center for Rural Health in cooperation with the Geriatric Education Center of Michigan, MSU College of Human Medicine, and MSU College of Nursing. Before we begin, please remember to mute your mic until the Q&A component at the end of the program. And then please remember to mute your mic after you've asked your question so the signal is clear and other sites are not listening to your conversations, and so the presenter can answer the questions. Handouts are located on our website at www.mcrh.msu.edu. Click on the education link on the top and then scroll down and then find today's date, and there you will see attendance forms, evaluation links, and as well as the handouts. Continuing education is available for physicians, nurses, and social workers. Each healthcare discipline has their own attendance or sign-in form, and everyone fills out the same evaluation by clicking on the link and completing it in SurveyMonkey. Attendance or sign-in forms need to be emailed, faxed, or mailed into the Michigan Center for Rural Health office. Sign-in sheets must be signed by a proctor, and the sign-in sheet must be returned to the MCRH office or you will not receive credit. Nursing attendance forms need to be filled out and signed by hand. And then please note that we are also not accepting paper copies of the evaluation. Physicians, please note, in order to obtain your certificate, you must also complete everything through the new CME portal. In order to do this, you must follow all the steps in the self-attestation page. If you have any questions, please contact me. I've also drawn out steps for this process, and they are located on our website. Please complete these forms within 2 weeks or by March 15th. Our speaker today indicates no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program. With that, I am pleased to introduce our speaker, Dr. Linda Kyleman, who will be speaking on applying motivational interviewing skills to older adults.
Thank you. Good afternoon, everybody. I have no conflict of interest, except that I'm really interested in this topic. And the objectives for today, I just want to describe motivational interviewing and how you can use it to reframe our communication in healthcare, and then how do we apply the principles to working with older adults. You know, a lot of people think that motivational interviewing is a new thing. It was actually really developed in 1983 by William Miller, who pioneered the use of motivational interviewing. And I'm just going to use the abbreviation MI, not for myocardial infarction, but for motivational interviewing today. It's a communication method that he employed that was client-centered counseling to elicit and strengthen motivation for behavior change. And originally, when he developed it, he used it as a communication approach for helping individuals who were problem drinkers. And then in 2008, in healthcare, Rolnick, Miller, and Butler really described an expansion of motivational use in addressing a wide array of health behaviors. So there's lots of research that has been done. We'll talk about a little bit about that today. But I think where we need to start is understanding what is motivational interviewing. So motivational interviewing, or MI, aims to promote and increase the desire or the motivation to change behaviors by exploring and resolving any issues of ambivalence the person may be experiencing. So, what is ambivalence? Well, it's a state of uncertainty or an internal conflict about the pros and cons of change, or whether we will be successful or not in trying to do something good for ourselves. And we all have this issue, even in our personal lives. So, it's not that different from things we've already experienced. So, really, some people act like motivational interviewing is this really difficult thing to learn, but it's not at all. Bottom line, MI is a conversation about change. It can be brief or prolonged, but it is never a lecture or a monologue. It's about guiding rather than directing. And it's also an evidence based psychotherapeutic approach to health behavior change, and to me has great potential to improve medical regimen adherence among older adults. So, bottom line then, if we talk about motivational interviewing, it started out related to difficult conversations with patients about risky alcohol intake. So there used to be, and there still is actually, so an inclination to confront or persuade patients to do better, to do the right thing. We could say this about alcohol intake, smoking cessation, weight loss, increasing physical activity, looking at a person and saying, you have to, you need to. And instead, motivational interviewing really evokes a person's own reason to change, which really minimizes their resistance. So the basic principle of MI is person-centered care, in which the patient's needs are the priority. And that's what's extremely important to remember. It's not about what we know from our education and experience that a person should do, but what are they willing and able to do? So, bottom line, motivational interviewing aims to promote and increase motivation to change behaviors by really exploring and resolving any issues of ambivalence that a person may be experiencing. So, ambivalence, again, is really wanting and not wanting the change at the same time. We've all been there. Want to do this, but gosh, can I afford it? Do I have the time? Can I do it? So it's things that we experience in our daily lives. Now we just want to translate it to our professional lives. And it's really looking at, is the change compatible or incompatible with what I'm doing at this time in my life? So the issue with ambivalence is that it can lead to anxiety, which can lead to procrastination, or others thinking that the person is resistant. And then it's very important to think that ambivalence is a natural condition of thinking about the pros and cons of change. The problem is that our patients can get stuck here in their state of ambivalence. They want to, but they can't. And that's where motivational interviewing as an expertise and a way of communication that healthcare professionals can help the older adults. Because MI really addresses the patient at their current state of functioning while addressing the varying levels of readiness for them to be able to change. Alrighty? So, who are they today? What is their function today? What is their smoking? What is their alcohol intake? What is their glycemic control? Their hemoglobin A1C, their blood pressure? We could go on and on. And then we have to know for their readiness for change and being non-judgmental, non-confrontational, and non-adversarial. And then if we think about it being empathy versus sympathy, and I'll talk about that a couple of times today because I think it's very important. Empathy really is looking at evolving perspectives, and it's really the ability to share an understanding of our patient's current situation and helping to the individual especially to understand that ambivalence is normal and not to feel bad about that. And bottom line is, you have to believe in motivational interviewing for it to really be used effectively and for it to work. So it's a conversational strategy, and it has been effective in eliciting health behavior changes in people in a variety of settings. And you have to believe it, though, because if you don't believe it, then it's not going to work for the person. And we'll talk about why that is, too. So when we talk about the spirit of MI, it's more than the use of a set of technical interventions that we're going to talk about today. It really is connected to a way of being and your presence and how you can be a therapeutic tool for your relationships with your patients. So this way of being is described as the spirit of MI. And it's the foundation of every conversation that takes place. And what it should do is communicate compassion, acceptance, partnership, and respect. So the spirit of MI is really based on 4 key elements. And the first of those is about partnership or collaboration. And collaboration really builds on rapport and facilitates trust in helping relationships, which can be really challenging sometimes, especially if the individual is looking at you as the person in control, you as the person with all the power, and they are powerless. And a lot of times we look at this as a patriarchal way of approaching patient care. And what we know from research is, bottom line, it really doesn't work. There has to be an equality, a relationship. So, and it also doesn't mean that the healthcare professional automatically agrees with the patient about the nature of the problem or the changes that may be most appropriate. We can certainly have differences of opinion. Although you may see things differently, the therapeutic process should be focused on mutual understanding, not the healthcare professional being right. And motivational interviewing is done with and for rather than to individuals, and we'll talk more about that. So it is really important that it is a true collaboration and mutual acceptance of one another. And then the second key element is acceptance, and that's really the understanding of autonomy and potential strengths that a person has. And we have to look at a person from a strength-based perspective and find out what is their strength and how can we build on that and utilize that to help us to work with the person. And then I want everybody to understand that there is no single right way to evoke change or to work with individuals. There is no recipe to follow. And because we're all different individuals, we will all approach it differently. So the third element is compassion. And compassion is the ability to actively promote the other's welfare and give priority to their needs. It's a deliberate commitment to pursue the welfare and best interest of others. That would be our patients or the individuals we're working with. It's also a commitment to seek understanding of others' experiences, values, and motivations without engaging in explicit or implicit judgment of that individual. And compassion is an understanding that everyone strives towards a fulfilling life and at times encounters barriers which can evoke feelings of sadness, pain, and shame. And that even starting towards a goal, we may be doing very well, but then we may fall back, and understanding that that is normal and normalizing that for the individual. And really, compassion is acceptance of one's path and choices and respect for the difficult emotions that a person can experience along the way. So the MI approach is one of the healthcare professionals where they draw out the person's own thoughts and ideas rather than imposing our opinions as a motivation, and commitment to change is most powerful and durable when it comes from the person. No matter what reason that we might think we're supposed to convince the person of the need to change their behavior, or how much we may want them to do so, lasting change is more likely to occur when the person discovers their own reasons and determination to change. So this is basically the fourth element, and that's evocation. And that is our job then as the healthcare professional is to draw out the person's own motivations and skills for change, not to tell them what to do or why they should do it, because that more is related to us or our experience in healthcare or what the literature tells us. And especially when we're dealing with older adults, chronic conditions, and what we know about if you don't do this, this may happen. If you don't control your hemoglobin A1C, this may happen. This may lead to. So we really need to think about that and think about these four key elements as important aspects of who we are as healthcare professionals, and then putting that into the way we communicate with other individuals. So I just want to give you a couple ideas of how the key elements sound when you put them into your conversation. So if we look at collaboration or partnership, then something you might say is, we are going to work together. And if we're really accepting of their autonomy or their independence to make decisions that they feel are best for themselves, something that we might say is, I value you and am delighted to talk with you. Delight is interesting. I'm on the board of a national gerontology nurse practitioner organization, and we put in our mission and vision that we want to delight our members, because that makes people happy. That makes people feel like you are listening to them and their needs. So I've tried to put that into my conversations with my patients and their families. So if we're using evocation, what might a statement sound like? Something like, I'm going to create a space for you to share yourself and your story with me. I've done presentations for geriatric grand rounds before on the person's story and how valuable that is in being able to work with older adults, understanding where they've come from, especially when they have a diagnosis of dementia. And then compassion. Something you might say is, I want to understand and respect you and your experience. So what then are some of the common principles that make am I different the most of our usual conversation that we have with older adults? Well, to begin with, it's about expressing empathy. Sympathy involves identifying with and even taking on another person's emotions. Nobody wants to be felt sorry for. You know, sometimes we can have our own pity parties, but then we have to snap out of it. And people, we can actually handicap individuals by making them feel so bad or their situation feels so terrible that, my gosh, how are they ever going to get better? You have so much to overcome. I don't know how you're going to do it. Think about different situations that you might have experienced. So, you know, a sympathetic response might be something like, you know, I'm really angry about people being late too. Or, I know how you feel. I had that exact same experience. I've heard that a lot. I really cringe when I hear that because no human beings are the same. You might have had a similar experience. You might have been in the same place at the same time, but the way you feel about that, the way you internalize something mentally, emotionally, spiritually is different than every other person that exists. So to say to a person, I know exactly how you feel, takes away their uniqueness as a human being and also their right to feel however they want to feel about the situation. And I think that's important for us to remember. Empathy means acknowledging and affirming another person's emotional state. So An empathic response might be, I can understand why people being late makes you angry. Then we're relating to it. We're not saying, oh yeah, I hate that too. So responding to patients with sympathy or getting as upset as they are puts you on an emotional roller coaster, and as a healthcare professional can leave you worn out and frazzled at the end of the session because there's so much what I call sucking out of your emotion because we're buying into their emotion and taking it on rather than identifying it and talking about it. So the trick is to be emotionally aware and sensitive without becoming too emotionally involved. When you respond with empathy, you stay calm and in control of yourself. It's only then that you can become your absolute best. You're ready, willing, and able to help the patient meet their needs and their goals. So showing empathy allows you to be professional and caring at the same time. It also makes our patients feel that they are important and what they are saying matters to us. Empathy cannot be handed out by a machine. It's something one person does for another person. So when we're talking about self-efficacy, we need to be sure not to impose our beliefs onto that person. As I said, MI is done for and with a person, not to them. Enabling, taking away the ability to learn and feel good about that learning doesn't do the person any help. And then when we're not with them, they don't have any good coping strategies or mechanisms to use because we're not there. And we need to help them understand that the more they practice, the more we practice, then it becomes a habit versus something we just do. My colleagues always say to me, you better quit doing this motivational interviewing stuff because it's now in your usual conversation all the time. Oh, I hear what you're saying. Oh, I just heard you say. It's not true. I don't do it all the time, but I do it a lot. But it does become, I don't automatically think about it. It's just who I've become, which that's how each of you should think, and then that's how we should think about the individuals we're working with. And then awareness of the consequences of change is very important, good and bad. If you're looking at people that have bad habits, say with drugs or alcohol, their friends usually are people very similar to them. So if they decide to change, then sometimes that means not hanging out with the people and the friends that you hung out with in the past because they haven't changed. So that's very, very difficult. And so we need to think about that and thinking about the discrepancies. And really, it's the person who really should present to us the arguments for their change and to help them understand that change is difficult. And then resistance and reluctance are natural, not a pathological response to change for anybody. Those of you who have raised children or are raising children, think about that. You say yes, they say no. You say no, they say yes. It's normal. It's just automatic. It comes out of your mouth. It's like, no, I don't want to do that, or I'm going to do this. It's one of the most important principles. When we're open and not destructive, it actually increases the person's feelings of acceptance. And feeling acceptance promotes engagement, and ultimately, it improves the chances of experiencing a therapeutic encounter. But it's also important to know that resistance is a predictor of poor outcomes. So, MI believes that persons considering behavior change experience ambivalence related to the pros and cons of change. We've talked about that. So, what are some of the key communication skills and strategies that you need to utilize? Well, when we talk about the 4 core skills, it's important. Acronym is OARS. So it's helpful for a discussion like lifestyle changes, setting behavioral goals, discussing medication use and adherence to that, developing plans of care in collaboration with the person. So, open-ended questions is using what, who, how, tell me why, not tell me about it, not why questions. So, a closed question might be, are you in pain? Well, that's assuming a person is in pain without asking about it, and then they can say yes or no. Versus an open question might be, how do you feel? Or, closed question might be, how much alcohol do you drink in a day? Well, research shows us that people usually, if they answer truthfully at all, they'll tell you 1/3 of the amount of alcohol that they drink a day. And then, really, how are we defining that? So, an open question might be, what role does alcohol play in your life? And then they might talk about, well, I have a cocktail with dinner. We always have a glass of wine before bed. We go out every Friday night with friends and have several drinks. Then they're telling us about their life versus what they do because they're going to be guarded and defensive. So because MI really requires a significant amount of insight and communication ability on the person's perspective, it may not be an appropriate strategy for older adults with cognitive impairment, although I do use that with my individuals with cognitive impairment, but you have to know them very well. So then what about affirmations? Well, that's noticing anything positive about the person. Maybe they combed their hair, they got a haircut, they got a new outfit, they dressed really nice, their jewelry matches their nail polish, they shaved their beard off, they grew a mustache. I mean, little things that make a difference when we notice it about a person because it actually makes them feel like, I remember you like this, and gosh, this is how you are today. There's been a change. So, any awards or attempts they've made, or accomplishments, or achievements, you might say to a person, "You really care a lot about your family," or "This is hard work you're doing," or "You were successful in changing in the past. I remember when you weighed 75 pounds more than you did. That was hard. Did that." Or "It took a lot of courage for you to talk to me today about this. Thank you." So we use affirmations to build a sense of self-confidence and self-efficacy in individuals. Reflecting is perhaps the most important skill, and it's about listening, and I'm going to talk more about that later. But summarizing is really thinking about what the person is saying. They're talking to you. They might make ambivalent statements like, "I don't want to move. I like my house. I would have to change healthcare providers. I'm worried about falling. I could be closer to my grandchildren. I might feel safer in senior housing." You summarize what they've said back to them. And some of the things that you can say are on the screen and in your handout. What I heard is, the picture I see is, what I am seeing is. So that helps them understand that you have heard them. It also allows them the opportunity to make corrections if we didn't see or hear what they're trying to get across to us. So what about the 4 processes then that are important to get from the bottom of the staircase up to the very top? How do we get there? Well, one of the first ways is engaging. And these steps are kind of sequential in nature because you have to engage someone before you establish or get them to talk to you. So that's just normal. So how do you go about doing that? And then in your handout, there's some disengaging ways. And this is kind of like what we do a lot in healthcare. Asking too many questions or telling them how to fix it or we're in charge and they're not. Labeling, a lot of labeling occurs. And, you know, I need to lose weight. So if the first thing somebody in my healthcare provider's office says is, well, you didn't lose any weight since the last time I saw you, then I'm like, no kidding. I didn't know that. I mean, it sets you up to feel like, yes, that's correct, I did not. So you're already a bad person then. So we need to think about how we do that. And part of engaging, is about feeling. How do you welcome people? Use the name that they have asked you to call them by. And I always approach my patients that way. I shake hands with people that can shake hands. It's a lot of assessment things. I know, can they see my hand and know that it's coming forward? What does their hand feel like? Their strength, the warmth, the texture, the moisture of their hand. Tells you a lot. And it's also touch, of human touch. You never know when a person hasn't been touched by another human being. Shaking hands is a way to gain connection. And that we should assume that all people can exceed our expectations if we don't set them too high. Because we can always change them. Short-term goals, celebrate them when they've been achieved and make the next goal. And we want to do mutual goal setting. It's not about us, it's about them. And then really helping to give them hope. Such an important concept. And then focusing. It's an ongoing process where, we're trying to hear what they need. We're trying to get them to think about ways that they can change. And what's setting agendas and considering goals and priorities, and then really having a purpose. And then you're using the ORS questions or skills that you're going to develop to accomplish. And what are those again? Asking open-ended questions so that they talk, affirming that it's okay to feel whatever way, reflecting so that we're sure that we understand what they've said, and summarizing at the end. And then really evoking. What is their motivation for change? And then we start to get into change talk. So we want to hear, I can, I wish, I want. The reasons are, it would solve problems, I will. We want to reinforce it when they say it, when we hear it. So you have to listen carefully. And when they say I can, it's like, that's fabulous. And ask questions. Open-ended whenever possible. And asking them like, what's your first step then? And then planning. How are we going to get them engaged and focused and starting to do change talk, and then going from very general to more specific? We really need to have a SMART plan. One of the ones that I like to talk to healthcare professionals is about smoking cessation. The important thing is to know how many cigarettes are there in a pack. Well, there's 20. So if a person smokes 2 packs of cigarettes a day, they smoke 40 cigarettes a day. A short-term goal would be, do you think that you could maybe decrease to 35 cigarettes a day when I see you in another month? And then we negotiate that. And we're not setting them up for failure because maybe they can do that. And in my experience, what I've usually found is not only did they reach 35, but maybe it's only 30. And then we talk about, okay, so you were successful this time. What do you think can be the next goal for 4 weeks when I see you? And allow them. If they say, well, I'm doing 30, maybe I could do 20. That's probably a little too many. So you negotiate and go back and forth with them. But then you also understand that maybe they'll go back, maybe they got down to 30 and maybe the next time it's 35. So you don't say, oh man, you you, what in the heck happened? You messed it up. Well, that's going to forget it, man. I'm going back to smoking 2 packs a day. So say, hey, we all have setbacks. You did fabulous. What do you think we can do for the next time? So that's what it's about, and it should all lead to the central premise of MI, which is to encourage the use of change talk, in which the person explores the reasons for change. So we focus on the person's present interests and their difficulties and try to resolve the ambivalence by eliciting and selectively reinforcing their change talk that will ultimately support their behavior change. So, what are some of the things? A person's change talk can be used to address discrepancies between their words and their actions. Saying they want to quit or they want to become abstinent, but they're continuing to use. So you need to do that in a non-confrontational way. What are the barriers? What's going on right now that maybe is preventing you? So find that out. And then one way of doing this is the Columbo approach. Now I'm probably, dating myself, but Columbo was a detective on TV played by Peter Falk in the 70s. There's reruns on the Hallmark Channel because I watched some of them over Christmas. But that guy was the coolest detective. He looked kind of frumpy because he was always wrinkled in his raincoat. But that guy never asked one straight question. He would always be like, well, I'm curious. Tell me about that car that you bought. And then the person would always incriminate themselves. And that's what we want. We don't want for us to be figuring out what's going on, but that we want them to figure out. So think about Columbo. So I want to ask you, when was the last time you really listened to the sounds that are taking place around you? Most of the time, we are surrounded by a whole range of environmental noises, and most of them barely register in our awareness. So much like the noise inside our own minds, external noises often go unnoticed. The noise in our mind and the noises in the world can both form an invisible backdrop to our entire life. So I purposefully listen every morning when I get up. Purposefully. This morning, I heard robins chirping. I didn't see them, but I heard them. And it gave me hope. And it made me smile. Because to me, when the robins come back, it's like, oh my gosh, spring is here. Now, we know it's supposed to snow in our neck of the woods today, but you know what? It's been warm for a long time. There's earthworms on the sidewalks. And I heard them, and it was like, oh man, this is exciting. So what else can we hear? If we employ reflective listening, then we are thinking about what that person, not their thinking, not what they're saying necessarily, not the words, but we're trying to understand what they're thinking and feeling and saying it back to them and conveying our empathy and understanding and trying to see their life through their eyes. And there's lots of ways that we can do this. So if a person says, like, I don't think I really have diabetes, I've heard that from a lot of patients, then you might want to say, so you're not so sure about that diagnosis of diabetes. And then they'll tell you why they don't think that's right. So some examples of reflective listening starters are, it sounds like you, it seems like you, you're feeling, what I hear you saying is, it sounds like you're concerned about, you're wondering if. So if a patient says, I know I should be following my diet, but I'm just too stressed right now, then your reflective listening response might be, it sounds like you are aware of all the reasons you should be eating healthy, But this is a very stressful time for you. And maybe they'll tell you more then. So think about using that. And then remember, empathy is not sympathy. Whereas sympathy is feeling for someone, empathy is feeling as someone. So tell me how you make good choices for yourself and family is an eliciting, or an illicit response might tell your idea of physical activity. And a reflective statement might be, your husband has a lot of influence on your decisions. And then they can talk to you about that. Or a reflective statement that you might make was, being strong, active physically, that is fitness to you. And then they can tell you something else. So why is MI a good technique or strategy to use with older adults? Well, it's about health promotion and wellness. It's about healthy lifestyles and disease prevention, management of chronic diseases. At the age of 40, we start developing chronic diseases, especially osteoarthritis, but it depends. Everybody's degree of disease is different. But we know the older a person gets, the more likely they are to have more than one chronic disease. So chronic disease, and I think motivational interviewing is a great way to help people with getting control over their chronic diseases. 50% of the deaths in the United States every year are related to chronic disease. And the PATH programs in your area offices really are working with older adults, and you should know about what's available in your community so you can refer people to those. But it's very, very exciting. So we might use motivational interviewing for discussing lifestyles changes, nutrition, physical activity, weight control, setting behavioral goals for a variety, almost all of the chronic conditions, discussing medication use and then adhering to that, about using a walker. If a walker might be useful, moving into assisted living from their home, stopping driving, which is extremely difficult. And I and the geriatricians that I worked with have found it very helpful to use motivational interviewing to help people stop driving, because most of them know they shouldn't be driving. They become afraid. Their car is dinged up, but it's very hard to take that last mode of independence away from a person. But use motivational interviewing for decreasing alcohol intake or smoking cessation, or maybe that they should attend adult daycare. They're living with their families, but their families, everybody goes to school and or work during the day, and they're really not safe by themselves. So do you have some types of programs in your community, or advanced care planning and end of life discussions? All of this is wonderful motivational interviewing to use with older adults. And then how are we going to determine their readiness, the importance, and their confidence? Is now the best time for this person to be doing this? How important is it? And how much do they believe they can accomplish the goals and change? That's very important. So some of the things, the facts that I want you to remember about older adults that don't necessarily happen, but it's important to understand the accumulation of grief, loss, and bereavement to most older adults. And this occurs over time, and it's more than just the death of individuals. Although death of individuals is extremely important, because the older you are, the less colleagues that you have, the less friends that you have. But grief, loss, and bereavement is also about loss of your home that you maybe lived in. Maybe you were born there and you lived there for 80 years and all your stuff is there, but you're not safe because the bedrooms and the bathroom are on the second floor and you have severe rheumatoid arthritis and heart disease. So you can't live there anymore. And maybe you have 2 cats, but the place where you're going to live doesn't allow you to take animals. That's a great loss. And the loss of all the material possessions in a home can't translate over to an apartment. So what do you get rid of? What do you keep? There's loss in that, even when a person understands that they need to get rid of those things. Older adults also have a lot of fear of physical illness, of getting cancer, of getting diabetes, of getting something that they know somebody else had and they had a terrible death. Loss of function, independence, loss of self. When they look in the mirror, they don't recognize the person that they see because they feel inside different than the person in the mirror shows them. There's fear of death in many people, even if they have strong religious, spiritual, faith, or cultural beliefs in death. Guilt over past events and not being forgiven or not forgiving others and still having anger. All of these things can have a negative impact on self-efficacy and can really have a negative impact on treatment adherence and our ability to help people to change. So how are you going to do this? There's lots of ways. I'm just going to talk to you about a couple. So here we have this line with 10 numbers. At 0 is not ready for change, and at 10 is ready for change. So you ask the person, so on a scale of 0 to 10, how ready are you to think about, and we'll just use stopping or decreasing your smoking? And then have them think about it and have them pick a number. And then a question that you might ask is, if you don't make a change, or if you don't decrease the amount of smoking, what do you think will happen? And maybe they'll say, well, I'm going to have to go on oxygen, or I'm going to get cancer. Whatever they say, we need to reflectively and empathically summarize what we hear them saying. And then you need to pick this, but where would you like to be in 2 years? Now, you need to think about the age of the person. When I was doing our geriatric fellows, and I was so impressed they were actually using this, but one of our geriatric fellows was using this for one of our patients who was 102. So they said to them, so where would you like to be in 5 years? And the person said, dead. I'm going to be dead in 5 years. And the geriatric fellow like, well, what do you mean? And they go, I'm 102. I'm not going to live forever. So you have to be careful. It's not, that's why we have to, there's no recipe for everybody. So, you know, you need to think about it. Here's another method. Same thing, you have the scale 0 to 10. So on a scale of 0 to 10, how ready are you to think about stopping smoking? So they decide. And then one of the things you can do is ask a backward question. So say they picked 5. You would say, why a 5 and not a 3? And you know, a lot of our patients want to please us. They feel that, and I is really easy. We need to help them understand reality. 5 seems to be a nice, even, number. It's 50-50. So why didn't they pick 3? And then maybe they'll tell you, well, I thought you might want me to say 5. Well, and then you get to say, no, I don't want you to say what I think you should do. What do you think you should do? And because you're the one that's going to have to do the work. Or you can ask them a straight question, why a 5? Or you can ask them a forward question. That would be, what would it take for you to move from a 5 to a 7? And who knows what they're going to say. So those are just a couple of the things that you can use. And, you know, it's kind of neat, but you have to feel comfortable with whatever you come up with, and that works. And when something works for one, it might not work for the next person, but you know all about that. We already do that all the time. So then, what is it that you can do with all this stuff that we just talked about? Well, learn how to use motivational interviewing for you to be flexible and collaborative, for you to understand that life is moment to moment. And while we wish that we could plan for tomorrow and next week and 2 years from now, we don't know where we're going to be or where our patient is going to be. So we should seize the moment and use that to help the person also seize the moment to know that we can go forward, but we can also go back. Develop some type of systematic method that works for you. Then we need to listen more than talk or give advice. I always tell all my nurse practitioner and doctoral students and medical students, nobody really wants your advice. What we would do doesn't have anything to do with what another person would do because we're not the same. So you need to talk to them about facts and say to them, we're not the same. Think about what's important for you. Then we need to guide rather than direct. To encourage the change talk, engage in some personal coaching, and practice. You can practice this on your spouses, on your significant others, on your children. And they won't even notice it, but all of a sudden they'll notice there's something different about you, the way you talk. You're going to get them to do the things that you want without them even knowing that they're doing what you actually wanted them to do. They think it's all their idea. So we're going to engage. Engaging is the process by which people establish a helpful connection and a working relationship. It can be instantaneous, where you're immediately drawn to a person or a patient, or it can take time and you have to work at it. So therapeutic engagement is a prerequisite for everything else. If you don't have that, it's not going to work. Then you need to be able to say to one of your colleagues, for some reason, I just can't relate to Linda Kyleman. Can you take her on? Because I think it's not really therapeutic, and maybe you would have a better relationship. Nothing wrong with that. We don't all click. We need to ask people for permission to discuss. And I've always liked this quote by Mary Lou Casey. What people really need is a good listening to. Sometimes just silence is all that's necessary. I've had that was the best thing. I didn't do anything except be there and listen. We need to think about those and versus but statements. I want to be happy, but versus I want to be happy and I am going to try. Affirmation, this is really hard. We know that change is hard. And summary, pulls together information the person has offered in the conversation. So what are the potential outcomes? Because that's what we're always looking for. For the older adult, it will help them with meaning and purpose in their life. It will make them feel good about who they are today, in this moment. And even if they're overweight and they're a couch potato and they smoke and they drink too much alcohol, it's still okay that they're alive because they add something to the world. And maybe they don't think that or hear that from anybody, so it's the opportunity for you to be a therapeutic tool to make them feel like that, which will improve their quality of life, which will make them feel like they need to change and want to change to be around for a little longer. And then for us, it's satisfaction about a job well done. It's feeling confident and good about what we've accomplished and go to bed feeling good and getting up in the morning and really being happy to go to our jobs because it gives us meaning and purpose. And for the healthcare system, we're talking about older adults with chronic comorbid conditions. It costs over $80 billion a year. Healthcare costs. 70% of healthcare costs goes to older adult and their chronic comorbid conditions that are in exacerbation. We can make a difference one person at a time. And bottom line, it's win-win for everybody, which is always a good thing. So I'd like to leave you with a quote by Franklin Delano Roosevelt. We have always held to the hope, the belief, the conviction that there is a better life, a better world beyond the horizon. I say you try motivational interviewing and see how good it makes you feel. And maybe tomorrow morning when you get up, just sit there in the quiet and listen to what's going around. Environment. Maybe you'll hear some red-winged blackbirds or a robin. Okay, thank you very much. And now we can take some questions.
Okay, so we'll now open the lines for questions and comments. In addition, we are now planning for for future grand rounds. So if you have like a topic that you would like offered, please make sure you indicate that on evaluations. Please state your site name first and then ask your question. Go ahead if you have any questions.
They do. So we can get out of here and finish up what we're doing.
Bonnie at Deckerville Hospital.
Doesn't have to
Yep,
be
go ahead.
just exact.
Can you
Go ahead,
suggest
Bonnie.
any further reading or materials to help me develop these skills in addition to practicing?
Yes, aren't there some references at the end of the...
No.
Okay, I will get those to
Me.
Victoria and she can put those up. I'm sorry, I usually include those at the very end and I guess I forgot this time. Sorry about that.
So Bonnie, she will get me a list of references and I'll post those later on today or tomorrow on the website.
Tomorrow.
Okay. Yep. So I will post references tomorrow on our website. It's okay. Are there any other questions or comments? We have some other feedback going on. We can hear conversation. So if you... Okay. Do you have any other questions or comments?
It won't.
No?
It won't let us unmute.
Okay. If we don't have any other questions or comments, or if you think of one later, you can either email me or you can email Linda. She did give us her contact info, or you can indicate that on an evaluation. If there aren't any questions or comments, we'll go ahead and end the program today. Thank you for joining us and have a great day.
Thank you.
Thank you.